So welcome to our evening or research presentation evening. Can I just ask that everybody check and ensure that you are muted? Thank you so much. When we do have a minute or so later, you are more than welcome to unmute yourself so that we can hear your voice. You may even switch on your cameras later, when you're asking questions. I do see a couple of familiar names on the list. Tammy, thank you for sending or sharing that. Then some announcements as we usually do. We still have, I would keep an eye out on your emails or your on e-commerce on the SASP website for any of our further offerings for the rest of the year. Let's just have a look. Helene mentioned here yes, there's a journal club running towards the end of the year. And I think we were still hoping to see what we can do in terms of a research presentations. Yes, so exciting things and everything that we have planned for our members. Eliane's hand is up. Eliane, are you able to send a message? Because Eliane is also
Sorry,
recovering from flu. Yes.
There's actually 2 journal clubs.
Oh, we still have 2. Sure. Yes, we have many. Okay. Thank you, Eliane. So there are 2 more journal clubs, everybody, that you have to keep an eye out for, and all for our CPD points. So this evening we are very fortunate to present you with an international speaker, someone that we as the Neuro group, so when I say we, I refer to us as the NEC. We met through one of our members, one of my ex-colleagues, Angie Klutter. So she linked us with Claudia Costa, who is a fellow physiotherapist in Lisbon in Portugal. So Claudia is going to speak. I hope I'm saying it correctly. I remember from the Congress last year where we met, your pronunciation of your name is Claudia. Huh?
It's perfect. It's perfect, actually. Claudia from Cloudy. Yeah, normally it helps.
So Claudia is going to speak about awareness of the vestibular system in neurorehabilitation. So Claudia is busy finalizing. She's finalizing her PhD project, and in her field or her current work area or the current area that she's working in is that of neurological rehabilitation and vestibular rehabilitation. She's working at the Atlantic School of Health, also as a lecturer, and she's been working in private practice for the last, without giving away any age, give or take 20 years. Almost.
Oh.
So Claudia has this very special interest in rehabilitation or vestibular rehabilitation specifically, and she's going to share some of her passion with us this evening. We are looking forward to that, Claudia, to hearing and learning from you, and all of us are excited to hear. I have clicked submit. It is gone. I have passed. I'm Dr. Claudia Costa.
Thank you. Thank you so much.
So throughout the evening, so what I'm going to do, everybody, I briefed Claudia before the time. So like I asked everyone to mute themselves so that we can pay attention and listen to what Claudia has to say. I too am going to mute myself and then just manage or look at the chat in the background. So Claudia, when you are ready, earlier on it worked perfectly. So if you're ready to share your screen.
I'm ready. Yeah,
Please, let's just see if
it works.
it should work,
Okay.
because it worked 5 minutes ago.
Yes, that's true. So see if it's working.
Yes, it is working.
It is.
Perfect. Okay.
Okay.
There we go. So thank you, everybody. Thanks, Claudia. I'm looking forward to learning from you this evening.
Okay, thank you so much. Thank you so much for your presentation. It's been 1 year, I think, that we met,
Yes,
and I'm really
it's a year.
yes. Yes, and I'm really thankful that we kept in touch and that we can do this. So yes, it's my passion, one of my passions. It's the vestibular system, and also because I came from the neurological field. It's a marriage that normally I like to do because nowadays and normally we don't speak a lot about vestibular system in the neurological patients, and it's really I think that it's important. So I'm really happy that I can have this opportunity, and I'm really happy that I can share with you. And let's think about this webinar more about, a conversation. And if you have any questions, anything, please interrupt me because I think that it's so much better when we have the opportunity to, discuss more than just exhibit. Okay, so please do it.
Thank you for that invitation, Claudia.
Thank you. Okay, so um, sorry, I don't know. Oh, yes. So this is a photo that we had last year. And as a disclosure, I don't have any conflicts of interest. So everything that I will share is just basic knowledge that I had, from my experience. So in this case, I will also like to invite to again thank and say obrigada because it's thank you in Portuguese for the Neuro Group of the South African Society of Physiotherapy because it's really important for us to create, bridges from across the world, because the way that I will share maybe will enrich your part, but maybe the way that you think will enrich mine also. So I think that all is an exchange, and I'm really happy for it. So I will present myself. I have my bachelor degree. So just for you to know a little bit of my journey and how did I arrive here. I arrived here because when I was in a younger age, I started directly my master degree. And when I started, I was already working with neurological patients. And I remember in one of the seminars, we had a professor that came from the United States. And then he was telling us and showing us a video of a woman that came really, thoughtful of her balance, and she was really scared. And then she did something about, some maneuver in her head, and she was fine. And she was like, dancing afterwards. And I was, what is this? It's really interesting, this way of, seeing things and helping people. And so with that matter, we started in the hospital that I started to work with vestibular patients. And because I came from the neurological field, I tried a lot of the peripheral strategies in the neurological patients, because a lot of them had, some alterations that were not coming from a peripheral lesion, but mostly from a peripheral learn non-use. So I started to use that, but at the same time I had questions because, in the neurological part, in the central diseases, we didn't have a lot in the evidence-based matter, let me say it like that. So for that, because of that, I did my Emory course also in the United States, because we didn't have anything here robust at that time here in Europe, or at my knowledge. And so I did the Emory course, and I started my PhD in neuroscience also to answer some of these questions that I just talked to you. So when we start as a clinician, we have like these big questions all the time, and we are really creative. And then when we go to the research, we were talking about a little bit before starting this, it's like a tiny, really little degree in order for others to climb. So, but I'm happy that I'm in that path, and so I just finished, I'm just trying to finish my PhD also to respond some of the questions, and knowing that I don't know anything, that I just need to keep going. So if you don't mind, I really like to, know the people that are here with me, acknowledge a little bit, the audience. If you don't mind, I have a little bit of a questionnaire here in the Mentimeter. You just have to put in your browser menti.com and then the code, and you will enter this presentation, okay? I will just give you, you are seeing, right, the code?
Yes, I can see the code.
Yes.
I can see the
And
code. So
you can, yeah.
menti.com.
Yes.
So our code, people, is 8
Sorry, I will just share.
Oops.
I will share in a minute again. I will share
Okay.
in a minute again. It's just because I need to do the presentation. Sorry again. Yes. Yes. Are you seeing it now?
We are seeing it. So can we?
Yeah.
I've lost the code. Okay, so there's the code is at the top of the screen
The top.
that
Yes.
Claudia is
Yes.
sharing, everyone. So
Yes. Yes.
menti.com
Yeah.
8448
Yeah.
3895.
Mm-hmm. Yes.
Okay, so now we can see. So a working context.
Yeah. Perfect. Yeah.
Okay, and we can see how people are answering.
Yes, are answering. We just give a little bit of time. Yeah. Just to,
Yes, I think
yeah.
most of our members will be either a rehabilitation center or even a private practice, whether it is in rehabilitation center or at a outpatient facility.
Facility. Yeah. So, yeah, I figure that that might be the case. And in a rehabilitation center, we will talk a little bit about it also.
Okay.
It's really important because a lot of traumatic brain injuries, for instance, on some strokes, they can have some impact also in the vestibular system. So, yeah. So it depends in the phases and in the types of patients that we have. So yeah, happy. So I think that most of the people already answered this one. I will just pass for the other one.
Let's see.
Mm-hmm. I think that this is
Somebody as they forgot to switch off their mic. Please, everyone, can I ask that you mute yourselves? Thank you. It seems like some of our members. Okay, there we go. Tammy, I see
okay.
Barbara also in the lobby. Okay,
Oh, that's
thank you.
great because
There we
a
go.
lot of people, a lot of people do not have training of vestibular physiotherapy in the undergrad, in the entry level, and we are trying. I don't know if you already answer. If not, I would like to send it. We are trying to know if there is any information or training of the vestibular system in the entry level because it's related to balance and it should be there. We think so. That's why we are trying to get it. Okay, that's good. So most of the people already have some training here in the vestibular physiotherapy. So in a postgrad point of view. Years of experience really fast, just for me to know also a little bit about you. Good. We are getting quicker. Perfect. You know, these things are really interesting, but sometimes they can take a little bit of time. But I think that it's interesting. Yeah. So most of the people with a lot of experience already in the vestibular, in the neurological field, and some with some training. Okay, and experience. Do you have a lot of cases in your clinical practice of vestibular dysfunctions? Okay, little. Little or no. Most of the people, so few of you have some experience or some cases of the vestibular. Okay, that's good. I will stop sharing this. Think that it's only one people that it's missing.
Okay.
Yeah. Okay, I will pass to my presentation again. Thank you so much for letting you know a little bit more. And now I will go to my presentation. Okay, so why this webinar and why we are going to talk mostly in a big part in the anatomy, physiology, and physiopathology. And after we will discuss a little bit how we can evaluate and how we can work with this kind of patients. The why is we need to know what it is, what the vestibular system act, how he's related with the sensorial motor looping, and why it's so important for us to understand the system in order to know how we can act, so how we can recruit it. It's the same for the neurological field, right? We need to know all the neurophysiology in order to understand how we can act, and in this case specifically, how it relates, how the vestibular system relates with the injury of the nervous system, can be the nervous system, the central nervous system or the peripheral one, but mostly of the central nervous system. So starting, we have movement and posture. And you know that between postures, we have always a state of movement. So it's movement that takes us from one place to another. And one of the maintenance, of one part in one posture, it's maintained also from really postural adjustments. So if we think, we are always balancing and unbalancing at the same time to create again a balance. So some of the times when we talk about unbalance, it's because the person didn't have the possibility to recruit or to adjust, because we are constantly in a looping of balance and unbalance. So I will just show a video, and then I would like you just to tell me what you think that it is.
Six halt bike. Notice that the patient initially has no symptoms, and then after a few seconds,
I'm very busy.
she's getting dizzy. Good. This is called the latency.
Stay there. You're doing a good job.
Also notice that after 15 or so seconds, her nystagmus and vertigo improve.
Okay. So what is this? You can unmute if you want. This is related with what we called normally loose crystals. So it's a VPPB. It's a specific maneuver to understand and to diagnose. And in this case, it's positive for the semicircle canal, the posterior canal, that normally it's related with this type of movement. Okay, I think that everybody's seeing me. Yes? Are you
Yes,
seeing?
we can
Because
see.
normally, yes, because
We can
normally I
see
do
you
some
also
things just to
use,
show you.
yeah.
Okay, thank you. Thank you, Adnil. So it's related to the perception of this movement. Okay, so this seems a little bit hard to understand because the vestibular system is really studied in an indirect point of view because the system have a lot of functions, and it's through these functions that we are going to understand if the vestibular system is responding well or not. So you're not how you say, it's really a specific thing to understand this type of nystagmus. So I'll just show you in order for you to know and to understand after how this is related. Okay? So talking about balance, we talk a lot about balance nowadays. Balance between family and work, balancing of, wealth, balancing about food, balancing about financial. We talk about a lot of things. What is balance? If we think about the word balance mean or equilibrium, if we're going to the Latin word, it's in a closed system is the achievement of stability, but it's a stability that comes from the complementarity of one place and another, from different forces and different players and different components. So this state of the system of balance results then in a stable context. That's why sometimes some of us are not so fan of the word static balance, because it's not static actually, it's a stable position. But it's for acquire this stable position, normally what we have, it's a group of muscles and a group of force that are organizing in order for us to be stable. And then if we have a displacement, we will have the ability to adjust again. If it was static, what it happens is, like in some kind of furniture, if I pull it off, it will fall, right? So balance means that it's a stable context that can also adjust between perturbations. So here comes the body balance, right? The body balance or the postural balance in the human being, it's have three systems that are really important. So vestibular, somatosensory information, and visual information. So this is the part of knowing where we are in order for us after to do the movement or to adjust the posture. So when we have the information of the vestibular system, it's along with the somatosensory system, information, a proprioception information. So it's the information of the body, right? And in the case of the vestibular system, it's from the position of the head in the space. So when we talk about the visual system, it's more stereoceptive. It's to know how the environment is and how the environment relates to us. So these three friends, as I used to say, normally have to say the same thing, or they have to be articulated. If some of them say something that it's not coherent with the others, what happens is that we will have a conflict, a sensorial conflict, and this sensorial conflict also will create symptoms, as we know, vertigo, dizziness, and so on. So these three friends, they work in a hierarchical system. That means that it depends on the context. So for instance, when we are in a stable environment with a lot of light, normally the visual field, so we have a lot of information from the somatosensory, of course, but the visual field takes a command in order to organize us. That's more what I want to say. So it's multimodal. We have more sensorial informations to work in the balance. But if we are, for instance, and this is this is a place that we have here in Portugal, that is Bairro Alto. This is the third photo. There is a place that is really uneven. In the night, doesn't have a lot of light. So we do not have a lot of information from the other systems. So we have to rely more in the vestibular system. And the same happens when we are doing, for instance, a looping. We have the other information, and the other information can help us, but we need to rely more in the vestibular system. So that make us think that depending on the context, we can recruit different components of this triad, okay? So, and when we talk, for instance, in the modify and the sensorial organization test, it's what it does. What it does is put the patient or the person in different contexts in order for them to, sorry, I talk a lot. I just need to know the time. So in order for them to have, the balance or the movement that we want. So if they work in a hierarchy, that's what it meant to be, but all of them are saying the same thing or are working together. It doesn't mean that some it's turned off. It just means that they are relating them in different positions. So which of these systems we know the least? Normally the vestibular system, right? And where it lives, the vestibular system. The vestibular system, it's in the temporal bone, and we have here in the end of the auditive channel, it's the labyrinth. So we have the labyrinth, the bony labyrinth, and then after, inside, we have the membranous labyrinth, and that it's between both of them, we have the perilymph in order to, support the labyrinth, the membranous labyrinth. So the vestibular system, it's considered a sixth sense. It means that we talk a lot about the five sense, but we know that we have other sense that normally we don't talk a lot, but they are there. And if they are not working well, we know that we have some problems also. We can talk about temperature, we can talk about pain, the sense of time. So all of this is feeling, the environment. So sense, it's feeling the environment. So that's why the vestibular system, it's considered the sixth sense. When we talk about some curiosities, just for you to know the specificity of this system, it dates back from 500 million years. So it's really, really ancient. The thing is that it's related even with, the evolution in the human being from the quadrupedy for the bipedy. So, the 2 points of support in the vertical position now. And it's implicated also in our verticality. So it's really important, and it's really hard also to study. So that's why, even being one of the most ancestral system, the physiological basis in studies only happened in the early 19th century by Robert Barani, when he did some studies with the rotatory share and the calorics in order to know the function of this system. So in order for you to know, the vestibular system, it's tiny. It fits in thimble, so it's really, really tiny. And nowadays, it's really, it's really evolved, this part of cyborgs and so on. But back, I don't know, 5-10 years ago, we still have robots like that, right? And why we had robots like that? Because they didn't have a sensor that could imitate the function of the vestibular system, because the vestibular system is giving us the information every time where the head is, in order for us to organize our postural control and maintain the eyes and the head in a stable way. Okay, so we can divide the vestibular system in peripheral vestibular system and in central vestibular system. And that's why we do have, how we say, we do have some central disorders that will affect also the vestibular system. So for this sensor is going to give the sense of position, movement, and orientation of the head in relation to gravity. So this system is one of the systems that is going to suffer when people go to space, for instance, because they need the force of the gravity in order to create the orientation. So that's why they need to have a specific training, because this system is going to be different in when we do not have any force of the gravity to relate to. So far, so good? If I'm talking too fast, please let me know.
No, it's perfect. I'm enjoying it.
Okay, thank you. Thank you. Some of the people have some questions, you know. So talking about the labyrinth. So the labyrinth is have a part, an anterior part that is the cochlea, and have a posterior part that is the vestibule. And the vestibule normally have 3 semicircle canals and 2 otolithical organs, and they are related to balance. I used to do this analogy. So hearing and the balance are two neighbors. So they are in the same place in an anatomic point of view. They are not related in a physiological point of view. So if sometimes we have a problem in the labyrinth, so in the cochlear part and in the vestibule, that means that all the labyrinth is affected. It means that is a problem in an anatomy point of view. Imagine if we have 2 families in the same floor and you have flood in the same floor, both of them are going to be affected, but they are 2 different unities. So it's the same here. They are only correlated by that. So the vestibule is, sustained in some membranes, and it's composed by membranes. I think that, I'm sorry, this video is not working. I will send you again, and this is the link. So it's suspended, and the sensorial organs of the utricle, sacral, and semicircle canals are going to be filled by endolymph. And it's important because the endolymph is going to stimulate the semicircle canals, and the utricle and the sacral is going to be stimulated by the crystals, the otolithical crystals. So that's why we will have after the VPPB in a dysfunction. So talking about the unity, the functional unity of the vestibular system, it's this hair cell that you're seeing here. So we have the hair cell and the kinocele, that is this part that is really big related to the stereocilia. There are the other ones. And this type of hair cell, it's in the final of the semicircle canal. So the semicircle canal, as you see here, it's filled of endolymph, and then in the end you have the sensorial nerve fibers. Here you see. So if these nerve fibers form after the vestibular nerve. So also in the otolithical organs, what happens is the cells, they are in a otolithical membrane. It's different from the semicircle canals. So here they have the membrane and they have the crystals on top of it. It's like we have a jello and we have some fruits on top of it, okay? So that makes the jello being it's going to be a little bit heavier, on top, because when we change the position of the head, the crystals are going to displace the nerve fiber, and that's the way, or the hair cells, and that's the way that this unit is going to be stimulated or inhibited. So just for you to understand, when this kinocele do stimulation, normally he goes away from the stereocilia. When it goes towards the stereocilia, it have an inhibition. And why this happens? This happens because every time that I have my head like this in space, I have information from one place and another of the vestibular system. The thing is that they are always being compared, from the central part. And we know if we have one information that is equal from the other part, it means that our head is stable and it's stopped. When we move our head, we have more stimulation towards one side and inhibition towards the other. So that's why these cells are stimulated and inhibit. And when they don't have movement, they have a tonus that is always there to maintain the information that the head is in the space. So when you talk about autolytical organs, what happened here is in the utricle, we have the utricle and the sacal. The utricle and the sacal are going to be disposed more or less like this. That means that the utricle have the hair cells like this to be sensitive to the linear displacement or acceleration. And the sacal is going to be like this in order to be sensitive to the vertical. So if you think about dollars, F like that, so sacal is vertical. And is going to be sensitive to the perception of the movement, but the perception only in the acceleration. That's why when we move our heads towards, when we move our heads, when we are in a plane, for instance, the acceleration, it's zero because the velocity is constant, and that's why we don't feel. It's the same when we are in a good elevator. We don't feel it because the elevator have a constant velocity, as we see in this video. So in the acceleration, we feel it, but when it is in a constant velocity, you don't feel it, okay? And then after, when we decelerate, we feel it again. So it's the same with, for instance, in a jump, acceleration, and then deceleration, and so on. The semicircle canals are not going to be, they are not, so the autolytical organs are the ones that are giving us the information in relation to gravity, because they have the autolytical or the otoliths, and they are heavy, and that's why being heavy gives us the information towards the force of gravity. Normally, in the semicircle canals, that doesn't happen at all, because what happens is that we have velocity that is angular. So when I move my head towards one place, I have the current, the endolymphatic current, for the other side. So when I do this movement, I have a current to the other side that is going to stimulate that part. So we have an anterior, posterior, in an horizontal canal, and the posterior, the horizontal, it's in 30 degrees towards the plan, the horizontal plan, and that's why normally when we do, for instance, the head thrust that we are going to talk a little bit later, when we do the head thrust, we do the flexion, because normally nowadays they say that it's not really important to do the flexion, but to put the channel in evidence. And Almaghi, when it did it, when he developed this type of test, he had this in mind. We put it on a flexion of 30 degrees in order to put the horizontal canal in evidence, okay, in the horizontal plan. So in the end of the semicircle canals, we have the dome, okay, and in the dome we have the air cells, and not being too profound in this, this is going to be important for the VTPB. When we have the right posterior normally here, is going to work in parallel or at the same time with the left anterior. So if we see this type of movement, so this is the posterior, the right posterior, and this is the left anterior. These are the movements, and they are in the same plane. When we're talking about the horizontal canals are in the same plane also, and they work as pairs. What we mean about these pairs, so as you see here in the video, and they are going to show you with the horizontal canals, when we move towards one place, we have activation in one side and inhibition in another. When we move towards the other side, we have activation in this side and inhibition in the other. This means that, this means that I know that I'm moving my head because I have an asymmetry of information from one place and the other. So that means when I'm stopped, the information is equal from one side and the other, but when I move my head towards the left, for instance, the left is going to be more stimulated and the right is going to be more inhibited. So, and it's this because we have the comparison, and it's this asymmetry that tells me that I'm moving my head. So again, if I move to this side, I move, stimulating, inhibit, and then I stop. I move to this side, I have stimulation and inhibition. And so that's why I know that I'm moving my head. So the information comes here from the inferior vestibular nerve, and then the superior that connect to the vestibular branch, and then it's going to connect also with the auditory nerve, giving the origin of the vestibular cochlear nerve, that it's the eight cranial pair. It's going to enter between the pons and the medulla, and here is going to be connected with the vestibular nuclei. And the vestibular nuclei is going to be a station for the information, and then it's going to send the information from all the functions that we need for our body. Okay, so I'll just do a quick, like 1 minute pause, just to know if it's fine for you, if everything's okay.
Well, from my side, it definitely is. Yes, and I see all the thumbs up from others. Very interesting and quite simple the way you're explaining things.
Okay. Thank you. Thank you. I try to do this. I try to be the most simple that it can, because I think that that's the way that we learn. But if it's too
That's
simple,
really
if you
true.
need more profound, I will also do it. Okay. Okay. Thank you, Adnil. Thank you so much. So the peripheral vestibular system, saying again, semicircle canals, autolytical organs, and then they are going to be connected and giving, finalizing here in the brainstem. And this is the part that is a part of the vestibular system, because a lot of people know, or normally we talk about the vestibular system. Oh, the vestibular system, it's in the inner ear. A part of the vestibular system is the inner ear. The sensor, the peripheral sensor is there, but then you have a lot of pathways that we are not going to detail them, all of them, but just going to talk a little bit about the main ones. And then you have all these pathways that are related with really important functions for us and really important function for the balance. So when I talk to my patients, because normally I talk to my patients and I explain them also this. I'd explain them that the vestibular system is connected with the other system. It's giving us the position of our heads, because I do think that people need to know and understand what they have in order to, control a little bit and be more empowered. So And then when I explain that, they say, well, what do you mean? I have a problem in my ear that is not related with the part of the, it's not auditory, but it affects my balance and my vision. So this is confusing. And it's confusing also for us, right? If you don't understand the pathways and the direction that normally the pathways give. So talking about really fast, the vestibular system, the central vestibular system. So all of the pathways that come from the vestibular nuclei. So the vestibular nuclei is here, as I told you, in the brainstem. And the vestibular nuclei is going to give, so they are four, it's a complex, they are going to be related with a lot of functions. So one of the functions that is really, really important, and I really would like us to do this with me now, if everybody's seeing me, put your thumb like this. I'm not seeing you. Normally, I do like to see you, but that's not a problem. If some of you can put the thumb and can put the camera on, I would like it. Thank you. Thank you. But imagine that we are like this, and now put it slowly and look to your thumb. And now really fast. Do you see it well? Kind of, right? It's kind of blurry, right? If we do like that. Now try to do it like this, but instead of moving your thumb, you're going to move your head slowly and then really fast. You see better your thumb, right? Than you see it before. Because now we are working with the reflex and the other would be a central oculomotor function. That means that we are working with the vestibular oculomotor reflex. And reflex means that it doesn't go to the higher parts of the nervous system, and it means that it goes directly to the nerves. And as we see here in this, in this slide, we have here beta. So we have the vestibular nuclei that is going directly to the three oculomotor nerves in order to do what? To do the movement that is opposite to the movement of the head. Because normally when I'm doing this and I'm fixing to you, if I ask you, do I move my eyes? Most of the people will say, no, you don't move your eyes, but I'm moving. What I'm doing is, when I'm turning to this side, I have an exact movement to the other side. So this is the opposite movement. This is the reflex. This is the oculomotor reflex. And why it's so important? Because when I move my head to this side, the vestibular information from this side goes directly to the oculomotor nerves from this side and the other in a conjugate point of view in order to stabilize the vision. So that's why when I'm walking and when I'm turning, I have the possibility of stabilize my head. If not, I would have a problem, I used to say, of a cameraman. So some of you can remember, because normally nowadays when I talk about this analogy, people don't recall it, but we had a movie that was Project Blair Witch that was all filmed with a handycam, and so all of what we saw was like this. Right? So our patients do have that. They have oscillopsia because the cameraman does not stabilize the vision. So the vision, the visual field is going to be moving while they are moving because they do not have the possibility of stabilize the eyes. Now think, we have to walk at the same time that we are seeing this. It's really, really heavy and it's really, really difficult because we also have all of the other reflexes like the vestibular spinal reflex that is also related with, the stability and the dissociation. And if the vestibular field is with the hypofunction and it's affected, it's going to be harder to balance and to create a balance because I will have how you say, noise. That's what the word I would like to say, a sensorial noise coming from the visual field, but I will also have a sensorial noise coming from the vestibular field. So if I do not know well where I am, the output is going to be impacted, right? It's like when we have hypostasy in one of the sides because of a thalamic lesion, we are going to have also an alteration of our position. So it's the same. It's really the same. This is the reflex. So also the vestibular, the spinal, the vestibular spinal reflex is also correlated not with the oculomotor nerves, that this is the vestibular oculomotor reflex, but the other is with, you know, the nerves, the crane, the Rashidyan nerves. They are coming from the spinal cord. So that's where we have the possibility of adjust, you know. So I move my head while I'm walking. I have the possibility, like the eyes, I have the possibility to contract here and relax here, contract here and relax here. And that's the way that I can do my dissociation, because I have the information of the vestibular field, the vestibular system. And then if we think about reflex, we know that reflex is different. So it's not a thing that is conscious. So I don't know the movement because of this pathway. I know the movement because the vestibular nuclei also send information to the thalamus and after to the vestibular cortex, that is in the parietal insular cortex. So there is the vestibular cortex, and we know that we are moving the head. We have the notion, the perception, because of this pathway. Another pathway that is really important is the pathway with the cerebellum for coordination. So the cerebellum, it's going to be the articulation, you know, of all of the segments. And it's really, just need 2 seconds. Yes, now it's done. So the cerebellum is going to coordinate, and to coordinate the movement, it's not related directly to the motor control, it's related to the coordination. So in order for the cerebellum to do the coordination, he has to also know really well where we are. And also the cerebellum is going to be responsible to organize and to coordinate our oculomotor movements, the central oculomotor movements, like we showed before, the smooth pursuit and the saccades, that we are going to talk a little bit more in detail. So the cerebellum has the looping. It gives, so we have information from the vestibular field to the cerebellum, and also from the cerebellum to the vestibular nuclei. And two other functions that I would like to know, I would like to share with you, is the vigilance, the conscious. So when I'm awake, I know that I'm awake, and normally my head is in space. So this information gives me more vigilance. Normally, when I'm sleepy, I start to do this. So normally when I sleep, I do this to my head, right? And if I do this, I take part of the information that comes from the vestibular system. So when the vestibular system is more active, we are more active also, you know. So that's why some of the times in the coma patients, I'm always doing this connection with the neurological field, because I think that it's important. In patients that are in coma, normally we sit them in order for them to be exposed to the gravity, in order for them to be exposed to some of these information, and also the vestibular information, in order to recruit the consciousness, right? So that's one of the pathways, and one of the physiological pathways that we are working in order to improve their conscience. And this is related with the reticular formation or reticular substance. Last but not least, and I will finish this part while I'm talking this, it's related with the hippocampus, but it's not directly, but it's related in order to, we need to know where we are in a cognitive point of view, also to have some mental maps. So oriental and spatial navigation also needs the information from the vestibular field. It's the vestibular system, sorry. It's like our internal GPS. I know when I go out from my house and I'm going to the grocery stores, I know the path because I already did it and I already have the sense how I did it. So it's also correlated with that. In some of the new new studies are going in this direction. So if you talk about balance, we cannot talk about balance only in the vestibular part. I love the vestibular system, but he's not the only responsible. It's a multimodal integration. And fortunately we have that because when we have some problems, we can compensate with the others, sometimes well, sometimes not, but it's an integration of all of the other systems. So we need to know. We have the sensors, and then we have the central pathway to process all of this information, to compare with the other systems also, and then afterwards we will have an output that is going to be related with the environment. Before I go to oculomotor, it's everything fine?
Yes, it was all fine. Thank you, Claudia.
Thank you, Adnel. Thank you. So now we are going to talk about the central pathways in the vestibular system. For instance, the smooth pursuit, that is this ability that we are seeing. It is controlled by the central pathways, and normally it's limited. That means that we cannot see, as we saw in the exercise, we cannot see it a lot, right? We cannot see a lot if it's really, really fast. But we have the possibility to follow if the target is not going to be in a really, so it's normally 2 Hz. In the saccadic movements, the saccadic movements are movements, as you see here, they are the displacement of the foveal vision. So foveal vision, it's the focal vision for a target there is in the peripheral vision, in the retinal vision. So I do this calculation, and again, who is responsible for the calculation is the cerebellum, as you know. And if I have an overshoot, that means that I have a lesion, normally a central lesion. And why we talk about these oculomotor functions, because they are related also with the central vestibular system. And if we have a problem here, normally it is a central lesion. It's not a peripheral lesion. And one of the why I'm talking with this and why it's important also to know that unfortunately a lot of vestibular syndromes seem peripheral and they are central, and that means that it's really important to be aware and to do the differentiation of one thing and the other. I will just pass this just to show you. So it's the same thing that I already told you, and the optokinetical nystagmus I will talk a little bit further. So I talked a little bit about the oculomotor reflex, and I will talk to you a little bit more now, because the oculomotor reflex is going to be one of the ways for us to know the function of the vestibular system in the peripheral way. So when the vestibular oculomotor reflex is the main mechanism to stabilize the eyes, as I told you, and we have a gain of more or less equal to 1. That means that when I turn my head to the left, I have a movement of my eye exactly to the other side, to the right, the exact same quantity of movement in order to be compensated. And it's really fast. It's more fast than the myotatic reflex, for instance. For that, we have this ability of stabilize. But imagine that my gain is less. So it means that when I turn my head, I don't have a really fast compensation, and I do this, and then I come back. I didn't have the possibility to stabilize my eyes. And to do this, to test this, normally we have the head thrust test. And what we do in the head thrust test, everybody's seeing me, right? Just put a thumb
Yes.
up. That's enough. Okay. Yeah. Thank you. So when I do, I flex my head, as I told you before, because I need to flex in order to have the horizontal canals, in evidence. I put it like this, and then the person is going to be in front, the examiner is going to be in front of the patient and is going to do the movement like this really fast. I will send you some videos, some tutorial ships afterwards, but in the sake of time, I just wanted to demonstrate it because I can demonstrate the normal and the pathological. So when it's pathological, that means that one of the ears is not, functioning well. When I do this and I turn the head, I will do this. I will have a compensation. This is normal. So the test is like this, really fast for one side to another. I'm testing the horizontal canals. We can also test the vertical canals. For instance, for the video head impulse test, normally we do that in order to see if the other canals are really affected also. But in a clinical way, without some specific equipment, normally we use the horizontal one. So we are here, and I do really fast to one side and the other. And why I do this? It's to know the function of the vestibular system. Because if the system is affected, the vestibular oculomotor reflex is going to have a delay. It's going to have a gain that is under 1. Okay, more or less, because sometimes to understand the gain, it's not really easy. So I'm trying to be as simple as I can. So this is the normal vestibular oculomotor reflex. As you see, the lady is turning the head towards one side and the other, and the eyes are moving towards the other side in order to stabilize the target that is in front of her. And this is the vestibular oculomotor reflex. Oh, sorry. Oh, yeah. So when I have the movement, again, the movement is because I have an asymmetry. And this asymmetry comes from the copular deflection, just to remember. But now I will ask you something. Normally we have, do you think that the vestibular oculomotor reflex is always there? Meaning, every time that I move my head, I have an eye movement for the opposite way. What do you think? You can put thumbs up or thumbs down also. I don't know if these have thumbs down. It doesn't have, don't worry. So what I mean is, it doesn't happen. Why? We have the possibility to do, for instance, this. I'm moving my head, but I'm fixing in my cell phone.
Yeah.
Yeah, I'm fixing in the cell phone, right? So the eyes are fixing here. And that ability, it's called as vestibular oculomotor reflex suppression or inhibition or cancellation. And this is a central capacity. And why it's important? Because it's also a test that we are going to do to know if the central part is affected or not. I don't know how it is in South Africa, but I know in some countries, some of the vestibular physiotherapists can be the first contact, or the patient can come referred from another professional, but it's important for us to be sure that it's not a central problem. And these tests can help us to do that, okay? And for this test specifically, what we are going to do is we're going to fix the eyes, and we are going to ask the patient to rotate towards one place and the other. So if he fixates well, the capacity of suppressing the VOR is there, but if it doesn't, it means that we are with the central lesion. And so if the patient comes with a peripheral category, let me say like that, and if it's have this sign, we have to be aware and to redirect again, okay? We also talked about this, but now I want to show you another thing. So far, so good? What is this? This is nystagmus. And nystagmus, it's a conjugated eye oscillation movement. It's involuntary, it's rhythmic, and normally change directions. And normally when we talk about vestibular problems, we talk about nystagmus, but nystagmus can have several origins and also can be physiological or pathological. So it's not the movement by itself, it's also the behavior of the movement and the context of the movement. What I mean with this is, imagine that we are in a train, or imagine that we are in a metro. When we see the metro coming, we will have a nystagmus. And this is called optokinetical nystagmus. And that's the video that I showed you. And so this optokinetical nystagmus, it stabilizes our eyes in a thing that is moving really fast. When I do the movement like this, when I move my head towards one place and another, I also have a nystagmus, a rotatory nystagmus or pararotatory nystagmus that is related with the movement of my head, because when I'm here, the VOR comes until here, but it cannot follow again, right? Because the head is here, so we have to come back. So this is a nystagmus. The nystagmus is an oscillatory movement. But it can be a response to something like an optokinetical nystagmus or a rotatory when we are doing it, but it can also be spontaneous and pathological. That means that it's because of a lesion, and normally a unilateral lesion, that we will have a nystagmus. And that's what we're going to talk a little bit more about it after. So when we talk a little about physiopathology. So, Adnil, I think that I'm more or less fine with the time. If I'm not, just let me know, okay?
No, I think we're still okay. Thank you.
Okay. So we know I need to know where I am to compare and select things that I already knew before in order to choose the body movement and to select the motor patterns that I already have. And we work this in a looping. And we physiotherapists and neurological physiotherapists normally know this for sure. And so we organize ourselves, and normally we think about balance strategies as a group of postural adjustments. They are more likely to happen to most of us because biomechanically we are really similar, right? So when we talk about the hip strategy or the ankle strategy or the step, it's some of the things that we learn through our lives. So the vestibular system and all of our system itself, it's independent of experience. So that's why when we lay down for a long time, when we have patients that are from more or less 2 weeks, 3 weeks laid down in the unit, and then we are going to sit them, they say, oh my God, I'm dizzy, I'm dizzy, I'm dizzy. They can be dizzy also from, the vascular part, the blood pressure and so on. We know that it's related to that, but also because the vestibular system did not signalize the information for the verticalization. Why? Because it unlearned to do. That means that we have a possibility to, so when we stimulate, we need to stimulate a lot the vestibular system all the days, because I'm here, I'm moving my head, I'm hoping that you also are moving your head like this or like this. So we are always stimulating the vestibular system. So it's dependent of experience. If we stop, then a lot of people are completely stopped, even to change position towards one place and another, they don't move the head. And so they learn to not use correctly the vestibular system. And so this thing make us think that these strategies, these balance strategies, they are important for us to assess, and they are also correlated with the vestibular system, because we are going to adjust having in account the vestibular information. And so most of our patients can have impact in this output. We can have, for instance, the ataxic patients that have balance strategies that are not really adequate to the balance challenge that they are having. For instance, when we are stopped, we don't need any balance strategy, but they will use, for instance, the ankle strategy. Or we can have a person, normally the elderly, they are fixed, they are always seated, or they are always using, a walker or something, and they have like this fixed position inflection, and they have like the hip inflection, and they cannot have the movement. They have non-neural limitation that will going to limitate the balance strategies. So also the system will not going to be really flexible to adjust the balance. So what I mean with this is that balance strategies can be related with the vestibular system. For instance, in the peripheral lesions, normally patients are more fixed because they don't feel well, they don't know where they are, and so because of that, they don't move as well because they do not know where they are going, and they might fall, and so they are more conscious of the information of their information in a balanced point of view. So they are more cognitive while they are doing the movement, and that have a cost, because we are made to be more semi-automatic when we are talking about balance and gait and so on. If you are thinking about every step, you're going to spend a lot of your energy, a lot of your cognitive energy that you need for other things. So turning this to the balance strategies, when we are when we are a child, normally we learn through error, right? So that's why we don't talk about the reflex, normally a postural reflex nowadays. We talk more, so neurophysiologically, it's more correct talking about a subcortical pathway for the postural adjustments. That means that we have a group of postural adjustments that we are learning through our lives. And because we are biomechanically correlated or similar, we will have similar strategies. And this being said, we will have alterations in or changes in a sensorial point of view, but also we can have in a non-neural point of view that will also affect the output and also the input. So for instance, the elderly, we can talk and we can accommodate a little bit better these balance strategies. Related to the balance strategies is the limits of stability. That means that if I'm fixed, I will have a limit of stability that is shorter, and normally in the units we will have a posturography in order to do a quantification. But also we as therapists, we can do it. Normally I say we can put a star in the floor, and because we do this, we can try to see if the patient can do more transfer to one side and the other, and normally we do it as physical therapists in the neurological field. And also we will see if the limits are altered. And because normally in the vestibular patients, they will have also these changed. So this is it's, as I told you, normally I step up in my own slides. So we know that we have direct reflex. It's our own reference, and it's our own reference in relation to the visual information. For instance, if I do this type of movement, now, if you do also in home, you can do it. You know that your field is moving, your visual field is moving. You know it, but you know that they are moving it, or the visual field is moving because you know your own movement, because the vestibular system is giving you the own movement, not only the vestibular system, but you have the information of your body. And the vestibular system, it's the most sensitive for the movement of the head and to the fast movement of the head. So if I do not have my information from the vestibular system, that means that when I have a movement in my visual field, it's going to be hard for me to differentiate if it's a self movement or if it's an out movement. That's why a lot of people develop visual dependence. That means when they do not like to be in the malls, they do not like to be in places with a lot of movement, because they are related, their own postural control is going to be related to the movement. I normally give this example. I had a patient that was a really heavy, severe patient. She had a peak stroke, so peak stroke normally can affect also the vestibular nuclei, and because of that, she had a lot of alteration and a lot of a lot of symptoms that resemble a peripheral part, but it's typical central. And I say, okay, you have to fixate a point. Fixation, again, you remember about the VOR suppression? You can fixate a point. And when you fixate a point, the visual system is going to create as an anchor. And because of that, you're going to decrease a little bit of symptoms. But then you can, again, change your movement of your head. And she said to me, okay, that doesn't work well in the weekend, because instead of a point that was fixed, she fixated a lift of a tree. The lift went, and she went to the floor also, because she was related with the lift as for her postural control. Just for you to understand better this part. So the perception of verticality, a lot of our stroke patients have problems of verticality. They are really flex. The ataxic patients, they have it, but we already know that the ataxic patients are related with the central vestibular diseases. So this vertical point, or this vertical way, it's coming also from the vestibular system. Other functions that we can talk, it's spatial orientation, as I told you, state of consciousness, but we already talked a little bit about it. I will pass to vestibular pathophysiology and then explain you more or less as we work with the vestibular field, okay, with the vestibular system. I can continue? Normally, I do these pauses because I think that it's important for us to breathe again and try to enjoy a little bit more. It's important. It's important to oxygen the brain. So, pathophysiology. What happens when it happens vestibular dysfunction? And don't think that it's only in the elderly, because it's not. A lot of young people have problems in the vestibular field, in the vestibular system. And what happens is that we have this group, as I told you, this group of information that it's, consolidated normally. Nowadays, it's more matured. So the vestibular system have more maturation, at 18, more or less 18 years old, because we are less motors during our childhood. So it's harder for us now, but at the same point, at the same state, we do mature it. And so when the brain do a comparison with the information that he had before, it is not the same. So do you remember the 3 friends that I told you? If the vestibular system is going to give an information and the other 2 is giving other, it's a sensorial conflict. And so it's this sensorial conflict that normally it's in the origin of these alterations or these symptoms. And I would like you to ask, how many of you learn or hear about dizziness syndrome, or, dizziness complex or context? You can put your hands, your hands up if you already learned something like a vertical syndrome, like a thing like that. We used to say that it's a term umbrella. It means that have a lot of things. And when we think a lot of things, we have a lot of symptoms that can behave in different ways. So when we talk about signs, we talk about, imbalance, we talk about instability, nystagmus, and so on. But when we talk about symptoms, they are really heavy in the vestibular alterations or the vestibular dysfunctions. So vertigo and dizziness, for instance, they are the main symptoms. They are really, really normally people usually use them interchangeably, but it's not true sometimes. Vertigo is the sensation of seeing everything moving. Dizziness it's more a head sensation. Normally people say, oh, I'm feeling a little bit off, my head is always, in the clouds. It's a symptom that it's more in specific, but it's more it normally prolongs more during the time, because vertigo, fortunately, it's not for a long time. It's normally it have a compensation afterwards. And oscillopsia, for instance, it's what I already told you. It's the inability to stabilize the visual field. And these symptoms, normally they are there. They are not there all the time in all the patients. It depends on the pathology. And normally vertigo and dizziness are really related, what we call a unilateral vestibular dysfunction, or meaning that we have a problem more in one side and not in the other, or one side is it's worse than the other. And why that happens, and we're going to talk really fast about these categories. So we can have vestibular peripheral vestibular dysfunctions or vestibulopathies. We can have central vestibulopathies, or we can have mixed vestibulopathies. And one of the things that we really would like us to talk more today and discuss it after, it's the mixed vestibular disorders, meaning traumatic brain injuries. They can have a concussion, or they can have a contusion or something, a lesion in the cerebellum, for instance, but at the same time, they can have a VPPB. Why? Because the peripheral and the central component is in the same place. It's in the head. So this means that and we have a lot of literature talking about that also, and I think that I sent some of them of this literature already, that a lot of traumatic brain injuries are underdiagnosed for VPPB or peripheral lesions. So they can have an affection also in the inner ear, and not only in, the central pathways. And sometimes we are working with them and they are not getting better, or we are not optimizing because we are not looking to this part. Of course, I'm not saying that it's the only part, but it's a part that is important for the rest, right? And also multisensorial deficits. That means that we can have, for instance, our elderly. And fortunately, the last World Falls guidelines are having these into account, but a lot of falls prevention does not speak about vestibular optimization or vestibular intervention. So we need to work, elderly people, they have weakness, that's true. They have muscle weakness, they have other types of sensorial problems, but they also have the vestibular system affected. And as we see until now, it's really important for balance and it's really important for movement. So it's important also to have it into account when we are talking about falls. But we don't talk, so we are going to talk a little bit, about the possibility or specifically what types of peripheral pathologies we can have. But we also talk normally about functional frameworks. That means that if I have a problem that it's more so, because as physiotherapy in a functional diagnosis, normally in a functional physiotherapy diagnosed, normally we want to know the functional part, right? And we do know, and it's important to understand the pathology in order to understand how it's going to affect this functional pathway, this functional context, but at the same time, the functional context is where we normally address. And so we have the unilateral hypofunction, meaning that one part is affected and the other no. Bilateral is both of them, and we can have a complete vestibular loss or we can have a central disinhibition. So this is the main frameworks that we can have. But paying attention that we have a particular disease that is VPPV or BPPV, sorry, in English, that is completely a part of this context or these frameworks. When we are talking about peripheral vestibular lesions, we can talk about labyrinthitis, we can talk about neuronitis, we can talk about sorry, I'm talking in French now. We can talk about Meniere's disease, we can talk about a lot of things. But that affects this component. When you're talking about central diseases, it's all the pathway, all the diseases that can affect the central pathways. So in the peripheral lesions, one thing it's a sign that is really important, that is the spontaneous vestibular nystagmus. And the spontaneous vestibular nystagmus, it's always pathological. It always comes from pathological asymmetry. You remember that I told you that when we move the head towards one side, the other side, it's going to be inhibited. So we have an asymmetry. What happens in the vestibular nystagmus, the vestibular spontaneous nystagmus? And it's spontaneous because nothing is recruiting them. I told you that we can have something visual that can recruit, and this is optokinetical nystagmus. But here, the patient doesn't have anything. What he has is a pathological asymmetry. So if he have a pathological asymmetry, meaning, for instance, that he have a labyrinthitis or a neuronitis in one of the signs, that means that he will have an asymmetry, and the perception will be that he's moving the head when he's not moving the head. That's why the vertigo comes, because we have a sensation that it's not correct. And so if he feels like he's having this pathological asymmetry, remember that we have the VOR that is always in the opposite sense of the movement of the head. So it's always in the opposite sense of the stimulation. So if I have this asymmetry, it means that I will have a VOR towards the side that have the hypofunction. But then we have two other friends that are telling the truth, right? The visual and the somatosensory system say, no, we are stopped, we are not moving. This is an error. And so the central system is going to do a reset. So that's why we have a slow phase that is related to the VOR and then a fast phase. So when we talk about nystagmus and spontaneous vestibular nystagmus, we are talking about a movement, a behavior movement. It's a movement that is composed. It's not a only movement. It's a movement that have a slow phase that comes from the vestibular system, and then a fast phase that comes from the central system for do the reset. And as you see here, tac, 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 this is a spontaneous nystagmus and is pathological. It's because of this asymmetry. Now I will do a rhetorical question, and I would like just to, for you to reflect. If I have a bilateral hypofunction that is equal in the same way in one part and the other, do you think that I will have nystagmus or nausea or vertigo or something? Normally, no. But it is a problem. It is a vestibular problem, because as soon as the patient moves, he doesn't have information from the vestibular system to have a correct pathway or a correct output. So that means these are the patients that normally they fall and they don't know why they are falling. And it's a vestibular problem also. So going back to the umbrella term that we talk about, the vertiginous syndrome, so a lot of people that have vestibular problems does not have, these type of symptoms. So these are related to the way that normally, if it is unilateral or if it is bilateral. So that's why for me it's really important talking about the anatomy and the physiology and the pathology, because then we can understand better what is happening with some of our patients. So when we have a bilateral vestibular loss, it's going to be, or a bilateral vestibular hyperfunction, it's going to be harder for us because we don't have a side that is well, but at the same time we do not have all of these. We do not have these other symptoms. Okay, but it's also peripheral. But we can also have unbalanced problems that are related with central lesions. So that's why it's important to do the differentiation. I'm almost finishing, sorry. So when we talk about neurological vestibular diseases, we should think that the neurological rehabilitation, some of the patients need neurological rehabilitation at the same time that they need vestibular rehabilitation, because some of them will have, a learn no use with that. They will use some of the strategies of maladaptive strategies in order for them to cope with their alteration. So this is a side that we should definitely pay attention. So this is a central. So when we have a central vestibular lesion, that means these pathways can be affected. It can be strokes, it can be degenerative diseases, it can be a tumor, it can be neurotoxicity. For instance, alcohol normally promotes, ataxia, and ataxia it's related with central vestibular diseases, and we should recruit also the vestibular system specifically. So now I would like to, break a little bit down here and I will just have a couple of slides after this. I know that I'm already in my time, but I would like to answer in the chat because we talked a lot about vestibular system and create a little bit of awareness, and that was the purpose here. But I would just talk a little bit about vestibular physiotherapy per se. And I would like for us to do this type of, exercise now. I will give a couple of minutes, like 2 to 3 minutes or 5 minutes, for you to tell me what you think that vestibular physiotherapy is for you, and what do you think that can be related or not to the neurorehabilitation, please.
Sorry, Claudia. Maybe what I can just do for the members is on our EduSASP system, people can't use the chat function, but you can use the Q&A function.
Okay.
If you want to, you put your thoughts there. And then we should be able to see that.
Okay.
Let's see. Claudia, can we maybe just repeat the question again? Or the questions?
Okay. Sorry.
So the questions was, what is
what is vestibular physiotherapy for you? I will put it here, actually. I'll put it in the chat. It's just for me to see the chat. Do you see it now? In the Q&A, I'm seeing it. No?
See. Yes, I can see. I see.
Okay. Perfect.
Elian or Tammy, can you see more than that? Or
I cannot
anybody,
see.
if you would like to, if anybody would like to, just unmute yourself and
And
speak up,
talk, yeah.
maybe, yes, and you can speak in terms of what you think vestibular physiotherapy is or is for you. I think that would be the easiest.
Yeah. If it's not working, we can do it
Okay.
in a different
So
way.
we have,
Okay.
it looks like someone, is it Marietta? Would you like to say something?
Okay. Yes?
I can't seem to hear. Okay, so Leon has made a comment there. Okay, so Leon says that she thinks that it's very important as it influences all of our movement. And Hakima mentioned or noted that one should consider this as part of screening systems when a patient with balance problems and a falls history, I suppose, when you assess, when you evaluate this. Yeah, for me, I was thinking as you were talking or asking the question, I was thinking in terms of yes, also along the lines of screening and assessment. Specifically when someone you what is happening and what we're seeing often a little bit more frequently is older people. That made me think a little bit, of physical changes, the postural changes, the stiffness, and the changes to the vestibular system because of that. Was something that I made a note of. Yeah.
Definitely.
So I think, yeah. And what is vestibular physiotherapy for me? I think it's all about movement, eh? It's all about movement, but also movement of, I almost want to say we're taking it back to our primitive reflexes, our head on neck, trunk on limbs, those, all those movements.
Yeah. Thank you. No, definitely,
Yes.
it is,
Okay.
it,
Oh, Marietta
yeah.
doesn't seem to. Tammy, are we able from our side to unmute? Are you able from your side to unmute Marietta Erasmus? And then maybe what she could.
I cannot unmute.
Okay, sorry. Thank you, Tammy. There we go.
No,
Marietta, it looks like you.
I was me. I responded I cannot unmute.
Okay, sorry. But it looks like Marietta, will you try to speak? Then we can.
Yeah, I think that you are unmuted, Marietta.
Yeah, it looks like it.
No?
But we can't hear. I can't hear Marietta. So it
Okay,
looks
no
like
worries.
she's unmuted, but yeah,
Okay.
no. Okay.
Okay. Okay, but we can, yeah. We can work with this. Yeah, it's really influenced all the movement, of course. Eileen, thank you
Yes.
for that. And
Yes, and then
one
also,
of, yeah,
Helen also
tell
moving
me.
about the object moving. That was also interesting for me. When your patient was looking at was it the tree, the leaves, and
Yes.
it might have, yeah, that was also
And
very interesting.
sometimes we are working with patients. And they say, I don't like to be here. It's a lot of, a lot of stimulus. It's a lot of people moving. So, because it's noise, they are
Yes.
dealing with a lot of things at the same time. And if they are not optimized, it's sensorial noise. And we need to be aware of that also. Sometimes it's not only cognitive, it's also sensorial noise that it's important for us. And I think that this creates a little bit more awareness about it also. And also we can use it for the sensitive. But now I'm seeing Marietta. No,
Let's see.
I was
just trying to see
hearing
what.
something. Okay, no worries. So
Okay.
I will just finish here with a couple of slides and then I will go to the Q&A in the sake of time also. Share. Are you seeing it?
Yes, there we go.
Yeah. Okay. So, before I ask you this, so what is the vestibular rehabilitation or vestibular physiotherapy? Vestibular rehabilitation is, trying to recruit specifically or selectively the vestibular system when he's damaged, or even in, cases as we have cardiorespiratory cases in the ICU, they are laying down for a long time and you need to recruit them. Some of the awareness of this system also in other patients that are not only in dysfunction. But when we have a vestibular dysfunction, it's important for us to do a specific evaluation. And the evaluation is going to be for the group of the alterations that the patient presents. We can do, for instance, the head thrust test that is here on top of it. That was the test that I told you that is really sensitive for the, for the movement of the head, for the VOR, to the function of the VOR. We can use also goggles to see the infrared goggles to see the movements of the eyes, the central movements and the peripheral ones, and also the pathological ones as the vestibular nystagmus that can be, spontaneous or can be provoked as it is when we do a maneuver, a BPPV maneuver, in order to know if the patient have or not a BPPV. That is the loose crystals, because what happens in the VPPV, that's one of the things that I would like to talk and I didn't, sorry, is the crystals that normally are in the octoconia, that normally are in the utricle, in the sacal, they go to the semicircle canals. Normally in 80% of the cases, they go to the posterior canal because it's easy because of the gravity force, right? And what happens is that the velocity is going to alter, right? The endolymphatic current is going to be faster, and because we have crystals there. It's like having a cup with ice. The velocity is going to be faster if I do it without ice or with ice. Here is the same thing. The crystals are going to affect the current. And that's why the patients only have vertigo and so on. Normally the vertigo comes when they move the head. But for us to know that, it's important to do, for instance, a Dixal pike. That is the maneuver that is down here. And these Dixal pikes show us if we have or not a VPPV, the posterior or the anterior. We also use a lot of PROMs, because PROMs are, patient-reported outcome measures, because as the patients with, pain, these type of patients have a lot of symptoms that it's really hard for us sometimes to quantify and for them to understand if it's better, if it's getting better or not. So we have a lot of different PROMs. We have the DHI, Disease Handicap Inventory. We have this, that is the VVAS, Visual Vertigo Analog Scale. We have the Vestibular Activity and Activity Confidence Balance, Vestibular Activity and Participation, measure. So we have a lot of different types of PROMs that can help us and can help the patient to have feedbacks of one of the things that is harder, that it's the symptoms. And one of the things that it's really a goal when we talk about vestibular physiotherapy is to decrease the symptoms. And then we can also use technology and so on, but all of this is tools for our basis, our clinical basis, or our clinical reasoning. So what happened, I'm sorry, this slide is in Portuguese because it comes from a book that I did in Portuguese. I would like to do it in Portuguese, in English, and I will send it to you afterwards. But what it says is that normally we have, for us to create compensation, we have a basis that normally it have three pillars. That is adaptation, substitution, and habituation. And I will talk better afterwards. But what this looping shows is that if we don't do correctly, if we don't do a specific stimulation in a good way, in the beginning, we can have the patient can have some kind of phobia, and because of that he will not move the head, he will not move his body, and he will create a looping of maladaptive strategies, and so this is going to chronify. For you to have a notion, a lot of people, most of these patients go through 4 to 5 professionals before they have a correct diagnosis. That's a lot of people, and most of them can quit before that, right? So they can create a maladaptive looping. That's what this means. So if we do the correct stimulation, the appropriate stimulation, we will have a decrease of the symptoms, and then we can have a good recovery. And to finalize here, what is the basis of our clinical reasoning is these 3 types of strategies. So when we think about strategy of adaptation, we are going to decrease the other two fronts. So vision and somatosensory, normally we are going to put, some foam in order to put the somatosensory information or input in disadvantage related to the vestibular system. We are going to close the eyes. We are going to do some movements of the head to stimulate better the vestibular system, always, of course, having into account what are the specific alterations of the patient. But the adaptation have this type of knowledge or way of thinking. So we are going to decrease the other two. So if you think about the sensorial organization test, that's what it does. So we are going to play with that. In the habituation, what we are going to do is we are going to use the postures that normally the patients say that have symptoms in order to desensitize. But here, it's important for us to know if the patient have other problems, like if he have cervical problems. If he have a VPPB, we cannot do this, right? Because we are not going to habituate him. So it's really specific, but it's also a different strategy that it's related with it's guided through the symptoms. And then we have substitution. That is, when we don't have any vestibular system to rely on, we have to substitute to replace or the visual information or the somatosensory information. For instance, the somatosensory information we have here, it's the balance belt. This is a vibratory belt. It gives the limits of stability to the patient in order for them to know if it goes, they are going towards the belt is going to vibrate, and they are going to organize themselves more with the haptic information and less with the vestibular because they don't have. And also we can create cognitive strategies. As you know, you cannot move directly. You have to look and then move your head and then move your body, because if you move at the same time, you will fall. So substitution is the last resource. It's what we call in the neurological strategies the compensation. So we only let the person compensate when we know that he doesn't have the potential to do, to recruit the activity in another way, in a more natural way. So these are the basics. To talk a little bit more than the time that I had, but I like to be more interactive. I hope that you like it. This is some of the resources that you have of the vestibular rehabilitation vestibular rehabilitation group of the American Society and Association, and then you have VIDA, that is also a group of patients. So I would like to share with you a place that I think that you know was wonderful for me to be there, and obrigada.
Thank you very much. Muito obrigado.
Perfect. You're
Is it?
perfect. You're muito obrigado, because you say obrigado. I say obrigada and you say obrigado. Perfect.
Thank you very, 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 very much for that, Claudia. I see, is it Debbie Cameron? Do you have your hand raised?
I will
Would you
stop
like,
sharing now.
or was that a mistake?
No, sorry, I was trying to send a clap.
Oh, okay.
Thank you. That's a very interesting talk and beautiful slides.
Oh, thank you, Debbie.
Thank you, Debbie.
I'm looking forward for your questions. Now I like, as you see, I do like a lot to talk.
You know what? I try to make notes while I'm speaking, of giving everybody else maybe a chance to, to gather their thoughts or gather their questions. But what I found quite interesting that you said, Claudia, was around people with, prolonged, were bedridden or bedbound for quite some time. Maybe like I think you used the example of someone in ICU who may be ventilated and, or bedbound for an extended period of time. I do think, yes, those should be the people where we would have, and that links to what Hakima said earlier on, you know, having a screening tool or being able to screen for vestibular dysfunction is a good skill to have for us as physiotherapists, because we are the people getting those patients up. And sometimes, especially if we do it passively, it can be quite fast. So if we lift with the help of nurses or physios or whatever, someone from a bed into a chair, it could be quite a fast movement, so that the velocity of that movement is fast. And now the body has not been used, they've unlearned or disused, how the fluids move in the different canals. So that was an interesting
Yeah.
one for me, or very practical.
Yeah, if I can jump on that, normally, I normally, before see some of the patient, if they are really bedridden for a long time, we can do simple thing as, move your head. You are there, just move your head, or maybe fixate, something in front of you, or maybe just put him. But this already we do, right? We can put him in a different, so not only in the horizontal, because we are changing the position, but because it's more passive, as you were telling in so well, it's more passive. The brain doesn't have the ability to deal with the thing that is really fast. So if the patient does something, or even if it's assisted by us, but it's moving before sitting, that could help also. Some of the patients, for instance, in stroke and the stroke unit, sometimes they think, oh, they don't have anything, and then they fall. Why they fall? Because normally they fix the head and they don't move the head. And when they are moving the head, they fall. So one thing, like, you just move the head. Okay. Thank you so much for that, Anil.
Yes, thank you. Thanks for elaborating on that. Is there anybody else that have a question or a comment or a light bulb moment that, if you've experienced a light bulb moment there, or, just a little bit of something that you took from this evening's lecture? Please feel free to unmute yourself and sharing. I don't see anything or anybody. And I know
I see Marietta.
Marietta seems to be trying here, but I can't hear.
but I have
Let's see.
some
Is there something
some
in the Q&A? So I know Hakima and Elian, they're struggling to get over illnesses, so their voices aren't what they what they used to having. So let's see what Hakima's written.
Hakim is saying, how would we adapt the approach if the PTF has cervical injuries that require immobilization or caution? That
Oh,
means,
Claudia, I think she had the first statement or comment that she noted down was, could you provide some
okay.
information on how you would incorporate vestibular rehab or practical ideas in patients with like from a traumatic brain injury in ICU or high care, and then the adaptation question comes after that.
Again, afterwards. I'm sorry. Okay, I will go there. So some of the things I already told you, right? We do need, and we know when we are in the ICU and with traumatic brain injuries and some cervical lesions also, we need to be careful because they are not stabilized sometimes, right? We have other things that we need to pay attention. We can have high blood pressure. We can have other things that are not completely well, but if we can incorporate some eye movements, some head movements also, or if we can, so before even the maneuvers, because I do think, imagine that a patient say to you, okay, I have a lot of vertigo. You can also do the maneuver, but you have to be careful to do it in a really acute phase, and that normally requires a really specialized person and normally an interdisciplinary team that can work with that in the ICU. It's different on when we talk about the rehabilitation centers, because some of them normally it's not a concern in the acute phase or the high acute phase. It's not a concern because sometimes they do not express at all that they have some vertigo, for instance, right? Or some dizziness. They are not expressing at all sometimes this. They are in another. So but normally in the rehabilitation center, they can say that they can express this type of feelings, and in this context, that would be also interesting to have somebody that could screen that can screen the function of the vestibular system, or if they have some VPPB that it's there and it's nobody addressed it, or if we have an impact in the vestibular function. For instance, if we work with these these variables, right, these sensors, if we put in a phone and close the eyes, and we have to be careful in there, right? It's not completely sensitive for the vestibular system, because we know that we have other pathways and other systems that also work on that, but can give us the sense that the vestibular system is also not helping it. Or, for instance, if we have a patient with a head that is forward or really fixed, he's not using correctly. So he's going to have what you were saying before, Abnil. He will have a disuse on learning. So it's not only it's not actually a vestibular dysfunction, but it's a vestibular disuse. And because of that, it's also important for us to incorporate movements of the head, or closing the eyes, or playing a little bit with the sensorial intermodal information. That makes sense?
Yes, what I'm gathering, or what I'm getting here, is that something as small, or it seems as small as eye movements, or opening and closing of the eyes and gentle movements of the head, is something that could be, in those,
Yes.
if we know that it's an issue earlier on, but usually,
Yes.
yeah, yes, because I have spoken to someone here in Cape Town that who this is also an interest of, and what she also mentioned is something very similar to what you said, is by the time patients with vestibular, or they are diagnosed with vestibular issues or with vestibular dysfunction, they've struggled for many, many years with this vertigo or the dizziness, the way that they can
Package.
express or
Yeah.
explain. Yeah. the symptoms that they have. Yeah, because it's usually not initial or fresh. It's usually way later that it's identified. All right. I was also very interested in the tools that you spoke of, because it is such a, I suppose it's a personal thing. It's like pain for a patient. It's something that they experience. We don't know what it feels like, but the patient, from the patient's perspective, we get we can measure the outcome measure, and that can also be quite a useful tool for patients in terms of, measuring their progress. Am I getting better? How much better? You know, so that was also very interesting for me. If we don't have any further questions from the floor, I'm also being cognizant of the time. So last chance, so if you have a question, please raise your hand. There's a written question. Let's see. Hakima says she would love to have a follow-up practical session, please. So that means somebody needs to fly down to Cape Town.
I would love to. Actually, I'm going to Angola next, like the end of October, actually. So
Okay.
I would love to do
So it's not that far from Angola to
It's not that far. So it's not that far. So
It's a
I
lot
would
closer
love to do that.
than Portugal.
Yeah. That's so true. So we just can arrange it.
We
I would love to go to South Africa again. It was such a wonderful time. Was really
But
amazing.
that is a lovely idea, Hakima. I do agree with you there, because there are, it is something that we need to understand, but it seems like they are extremely practical and,
Yes.
for lack of a better word, simple solutions to the problem that our patients present with. Helene said there that we should come to Bloemfontein. Bloemfontein is right in the middle of South Africa. You haven't been to Bloemfontein.
No, only Cape Town. So I would love.
It's
I would
about
love to go.
I think Bloemfontein is about 1,000 kilometers from where we are. From
Marietta?
Is it Marietta trying to say something? I can just hear static in the background, and I can see that the ring around her name is becoming active, but unfortunately we can't hear Marietta. Also nothing from you also can't hear anything that she's trying to say.
No,
Okay.
I'm not. I'm
All right.
sorry, Marietta.
Yeah, I'm
But
so
we will
sorry
have
about that, Marietta.
possibility. So
So,
I shared my. Oh, she's trying again.
uh,
Okay, I'm sorry, but I shared my. I don't know if you got it, but I shared my email. So if you need to reach out for something, I will be more than glad to help you. And yeah, I think that's I can agree with you more, Adnil. You know, these patients, they need advocates, normally I say,
yeah.
people
Yes.
that
No,
know and can direct them. And normally I say that it's not, you don't need to know how to treat it. You just need to know where to lead them, because
yes.
this is more than anybody is doing for some of
Yes.
them. So
That's
it's
very
really, really
true.
important. Thank you for that. Thank you.
Thank you so very much for this, and thank you very much to everybody that listened, that joined us this evening. Claudia, we really appreciate the passion with which you, presented this, and with which you shared your passion for vestibular, understanding and being aware of vestibular problems, of vestibular dysfunction. Elaine, do you have your hand?
Yes, Adnan. Thank you, Claudia. It was really a pleasure having you and hosting you and to work with you. Just a reminder for everyone to complete the questions that will be available from tonight to receive their CPD points. So, but thank you so much, Gloria.
Thank you. Thank you so much, Helen. Thank you so much.
Thank you very much, everybody. We really appreciated your attendance this evening. Thank you so much.
Thank you.